on novel therapies in renal cell cancer, or that's leading mainly to immunotherapy. But there are some targeted therapies that have been used to treat renal cancers, and how they can affect, in a bad way, the native kidneys. And there are several lines of chemotherapy that has changed for renal cell. Before, we used to just have interleukin therapy, which was really sepsis in a bottle. And now we have all these targeted therapies mentioned on both figures here that really revolutionize the treatment for renal cell. The chemotherapy world has really changed. You probably are familiar with these alkylating agents on the left, like cyclophosphamide, and then you have these cisplatin and things like that. But and we know some of these are nephrotoxic. But then lately there have been these novel agents that are coming out that are more immunomodulatory and directed targeted therapies. And this slide is borrowed from Dr. Parazella, one of my other mentors during my residency, showing the effect of all these chemotherapy agents in the various parts of the tubule, starting from the glomerulus, the endothelium, to tubular interstitium, to the collecting duct. So, and what we will be focusing on some of these targeted therapies, mainly, bevacizumab and mTOR and tyrosine kinase inhibitors, and then eventually get to the more happening things like immunotherapies. So let's start with the first case. Mrs. Smith is a 52-year-old woman with renal cell. Her oncologist has started her on sunitinib 6 months back. Her metastatic disease responded very well to chemotherapy. However, she had noticed her blood pressure worsening. New blood pressure medications were added, and she was up to 4 medications. However, her blood pressure still remained uncontrolled. Then her serum creatinine is 1.2, and her urine protein creatinine ratio is 4, up from 0.23 6 months earlier. Okay. So what does this patient have? This is a figure I borrowed from Dr. Carlos Flombaum at Sloan Kettering, and this is what happens when the clinicians in the room miss the big picture, or the elephant in the room, and goes back to Dr. Ranke's initial talk on thrombotic microangiopathy. And this is the problem with the diagnosis and why we have a problem clinically as nephrologists. This is your hematologist looking at the hemoglobin trends and platelets and chugging it. Oh, this is probably just a chemo effect. This is your cardiologist, the wrong specialist to send patients for hypertension management, and they never check a urine, and hence you're just managing the blood pressure, keep adding blood pressure medications. And this is a nephrologist now checking urine and noticed 4 grams of protein, but nobody's putting this whole picture together that it's a downtrending hemoglobin, downtrending platelets, worsening hypertension, and then worsening renal function and proteinuria, which is all really endothelial damage. And so I think people are forgetting as clinicians, and we have to keep reminding them as nephrologists and pathologists, that this is a syndromic disease. You don't have to have HUS or TTP. You can have thrombotic microangiopathy or endothelial damage in a more limited setting. It could just be renal limited and very subtle. If you don't look at trends, you're going to miss it. Rising LDH doesn't have to be abnormal LDH, a downtrending platelet, worsening hypertension requiring significant blood pressure medication being added, uptrending creatinine and uptrending proteinuria. You don't have to really have all the components, but a high level of suspicion. And I think one of the first signs, in my opinion, is rising blood pressure. And if more than 2 blood pressure medications are required, I usually tell oncologists that's when you send the patient to the nephrologist and look for thrombotic microangiopathy. It might be the first sign, not the cause of the TMA, but might be the symptom of the underlying endothelial damage. And this is where the whole conundrum that Dr. Ranke also mentioned about hypertension causing TMA, which I don't believe exists either. Targeted therapies are slightly different. Like traditional chemotherapy agents act on all dividing cells, whereas target therapies are more specific to the target, so anti-VEGF, anti-tyrosine kinase, and things like that. But we wouldn't be talking here if they didn't have off-target effects. And as you can see here, a lot of these targets are present throughout the kidney: the VEGF, PDL1, PDGFR, epithelial growth factor, A lot of these are present, and a lot of these are the targets for these chemotherapy agents. What I tell my colleagues and my fellows is that you can learn most of nephrology from onconephrology, because a lot of these target therapies can cause pretty much almost all of nephrology and all of pathology. So by hypertension, proteinuria, AKI, and electrolyte detox have been described as targeted therapies, but the most common pathology that's seen is TMA, AIN, or ATN, but TMA being the most common with some of these targeted therapies, especially the angiotensin angiogenesis inhibitors like bevacizumab, and the multi-targeted tyrosine kinase inhibitors like sunitinib, sorafenib, pazopanib, which you might have heard of. And a lot of these medications, while they're direct VEGF inhibitors or VEGF trap inhibitors, some of these tyrosine kinase inhibitors have some downstream effects on inhibiting VEGF, and hence leading to the same type of pathology you would see with anti-VEGF therapies like bevacizumab. And even you would be surprised, and I know Vanessa and I have seen some cases, even intravitreal VEGF treatment for macular degeneration and diabetic retinopathy can lead to renal limited thrombotic microangiopathy. So again, a high level of suspicion from the nephrologist and the clinician to ask these questions on what medications they're on. And just, basic oncology that you need to be aware of, tyrosine kinase inhibitors come in two types. And a lot of these IBs and OBs that you will see are hard to keep up with. I can't keep up with them. I usually have to look them up. And you will be surprised, most of them have somewhere they have an anti-VEGF effect. So you will see some of them are more endothelial toxic, some are more tubular toxic, and some are more, interstitial tubular toxic. So they do have some of special liking to the part of the kidney. But in general, the anti-VEGF inhibitors can cause these four syndromes, and all of them have been described in the literature. What hypertension, happens with these VEGF blockade is very, very complicated and not really well understood. But most people now think that it is a decrease in nitric oxide and endothelial dysfunction that eventually leads to hypertension and some volume overload component. So, it's not a renin-mediated hypertension, it's not a direct volume overload, but it's more of a nitrous oxide effect and direct endothelial damage. And the blood pressure rise with the agents is within days, and 18 to 30% of them get this activated blood pressure. And actually, when you get the high blood pressure, it means that the cancer is responding to the treatment. And the proteinuria is a direct effect on the podocyte, as well as the endothelial damage that can lead to further proteinuria. And so you can have a decreased VEGF, systemic circulation, endothelial dysfunction, and trophic effects on the podocytes leading to proteinuria. This is similar to what we would see in preeclampsia as well. And as you know, this old study, but a classic study from NEJM, by Armina et al. And Susan Quaggan's group, showing that when you deplete VEGF in the mice model and then even conforming it with Avastin, you actually can get thrombotic microangiopathy and podocyte effacement, intraglomerular thrombi, noded and endotheliosis. So this injury is the most common injury with anti-VEGF therapy. Again, very similar to what we would see in preeclampsia. Again, I try to highlight this concept for at least the clinicians, that we should not be just focusing on HUS and TTP, but more of a syndromic thrombotic microangiopathy. And just again, to reiterate that this can happen with various of these chemos, either through direct endothelial injury or to decrease VEGF causing endothelial injury, and some of the other chemos that can cause ADAMTS13 autoantibodies causing endothelial injury, or sometimes complement-mediated endothelial injury, all causing the same pathology for you guys. And we need to figure out, as nephrologists, what is the culprit. The management of the hypertension and angiogenesis is really, it's really bad nephrotic syndrome or TMA to stop the agent and treat the hypertension with ACEs and ARBs. There have been cases of giving eculizumab and a large series just recently published of Avastin-induced anti-VEGF from UPenn. But again, it's not very data-driven, more case series and case reports. It's challenging to give somebody with active cancer complement therapy. We don't know if there's going to be effects on the cancer getting worse. So again, the cancer diagnosis, the cancer treatment beats the renal disease. They can still get dialysis and get their chemo. So it's not very easy sometimes how to tell these patients. This is for immune checkpoints, which is to fight off cancer or infections. One is CTLA4, and the other is programmed cell death of PD-1 and PD-1 ligand. So just some of your transplant pathologists here know that you need two molecules to stimulate the T cells. You have the co-stimulation and the antigen, meaning the dendritic cell. And that co-stimulation is done through B7 and CD28. And CTLA4 is an inhibitory signal so that you don't get too much activation of the T cells. Okay, so you do not want to have, you want to have some policing of the activation of T cells. That's normal. And the same is done with PD and PDL1. So the tumor cells have PDL1 and PDL2, and the T cells have PD and PD1 so that they can block the tumor cells from producing and reproducing. That's what the T cells are supposed to do, and this is sort of the policing effect. Now, if the tumors can actually get very smart and create these ligands to block the PD1 of the T cells, and hence there is it's this constitution of inhibition is there. If you actually block CTLA4 and block PD1 and PDL1, you actually have constitutively activated your T cells rather than blocking that inhibitory molecule, and hence the cancer can get rid of. So this is what the CTLA4 inhibitors or PD1 and PDL1 inhibitors do. They are negatives, and they basically constitutively activate your immune system by activating the C cells and remove that inhibitory molecule, and that's how they fight cancer. And these are the sort of the more common drugs that are out there: ipilimumab, which is CTLA4 inhibitor, PD1 inhibitor, and PDL1 inhibitor. But what I'll talk about is mainly these three up on the top, the most commonly used. And you can see now almost for every cancer you can think of. But really, we started with melanoma and renal cell. And just as you can activate the immune system to fight cancer, you're going to activate the immune system and have itises everywhere. So that's why the side effects of these drugs are itises: hypophysitis, thyroiditis, myocarditis, inflammation pretty much in any organ. And that's where even the kidneys would come in. The most common actually is colitis and thyroiditis and some pneumonitis. So a 69-year-old patient with hypertension, GERD, on PPI is recently diagnosed with metastatic renal cell. She started on treatment with IV pembrolizumab, a PD-1 inhibitor, and 3 months later is noted to have AKI with rising creatinine from 1 to 2. The kidney biopsy reveals, like I said, it's going to be an itis, and most of these patients have an interstitial nephritis. So the AKI incidence with checkpoint inhibitors was nicely studied by the Brigham group and found to have an incidence of around 2 to 3% when you actually look for a specific cause of AKI with these patients being from the checkpoint inhibitor. And the biggest risk factor was being on a proton pump inhibitor. The largest study to look at biopsies of these patients was a multi-center study over 138 patients, again, led by David Leaf at the Brigham, collected over the country, 138 patients. And the ones that were biopsied, the most common biopsy finding was AIN in 93% of the patients at time of median of 14 weeks. And again, the risk factors of being on PPI was, again, keeps coming up, and combination of checkpoint inhibitor use and low GFR. So diagnosis of AIN, the most common finding with ICI, is not easy. As you know, AIN diagnoses are not easy for clinicians without a biopsy. People have tried different ways to diagnose these, through eosinophils and this and that, but really nobody should be using eosinophils anymore in the urine or serum. It really doesn't help. Fevers, rashes doesn't help. A lot of these present very, very strangely with just AKI. So biopsy is most of the time the gold standard. The mechanisms is very, very interesting and just postulations. One of the mechanisms is that autoantibodies against the kidney tissue that are formed. Another mechanism is T cell recognizes drug antigen against the PD-1 receptor, and there's loss of tolerance. And three, it may be the cytokine release that's causing it. Most of us think that might be the loss of tolerance, and that's why then there's a second hit. Patients are usually on PPI or NSAIDs or other antibiotics, and then these drugs kind of make you lose tolerance, and then you get attacked and get AIN. The risk factors, again, multiple studies have shown this PPI, CKD, and combined therapy, and some of the other risk factors have been other organ involvement and hypertension as well. So if there's another itis, like a thyroiditis or colitis going on, there's very likely there is nephritis as well. So this is a sort of a mechanistic view of how we would approach these patients, because a lot of these patients have solitary kidneys and we can't biopsy all of them. If there is stage 1 AKI, you rule out alternative causes and pre-renal obstruction. If resolved, continue checkpoint inhibitor therapy. If AKI is not resolved, you stop PPI and ICI therapy, and nephrology consultation should be sought. If the nephrotoxicity is from an alternative cause and if resolved, can resume ICI therapy. But if it's from ICI, and if there is another organ involvement and a high suspicion for AIN, you can stop the PPI NSAIDs, and empiric steroids can be done for 2 weeks. But there's no improvement, then a kidney biopsy should be done. But there's also, if there's a failure of empiric steroid trial, and there is proteinuria, hematuria, or some sort of signs that there might be glomerular findings, then a kidney biopsy also should be done. And then treat based on the kidney biopsy finding. Sometimes steroids don't work, and we have to resort to other drugs like mycophenolate or infliximab or rituximab to treat the immunotherapy-related toxicities. The treatment matters because if you treat with steroids, they actually do better in terms of renal recovery, and even a recent study from Spain showing mortality. So here is a study showing if they did not have renal recovery versus recovery, the mortality was worse when they did not have renal recovery. So a biopsy of our patient showed acute interstitial nephritis. ICI was discontinued and patient was treated with prednisone. The renal function improved back to baseline. But the oncologist wants to restart now the immunotherapy. So what will happen? Could AIN come back? What's the data on re-challenge? So the re-challenge has been studied in small groups. 2 of these studies are from Mayo Clinic. Most of the data is 19 to 25%. So there's 1/4 chance that the AIN will come back. So I think we can take that chance and let the patient get the treatment for the cancer. Here's a real case that Vanessa and I saw that will highlight some of the other pathology that we see. An 81-year-old male presents with rising creatinine and proteinuria. 10 years prior, he had localized prostate cancer and required radiation and went into remission. In 2017, he was noted to have new lymph node and lung nodules and bone lesions. He gets a biopsy, confirms melanoma, and treatment is begun with nivolumab, and that was given 1 year from December 2017 to 2018. His creatinine started to rise since March 2018 and was up to 1.6. No workup was done at that time. 1 year later, in March of 19, creatinine is now 2 to 3 range. In September 2019, creatinine is up to 5 range, and there's hydro. Gets a percutaneous nephrostomy tube, but there's no change in creatinine. Proteinuria is 4.5 grams, and there's low albumin. A PET scan reveals no recurrence of disease, so the melanoma is gone. The urology says there's no signs of prostate cancer. Given the progression of uremia, he started on dialysis. The labs really showed really severe renal failure, negative serology except for high CRP. PSA was elevated slightly, but there was no disease. Anti-GBM, ANCA, everything was negative, and he was on these medications. And the biopsy shows sort of these nodular-like lesions that initially show up, and then you can see that on Congo red, you have the bifurcation staining coming up, and the kappa and lambda are clean, and then you have your protein A strongly positive, and your EM showing randomly arranged fibrils, some of them, 8 to 10 nanometers. So the diagnosis was AA amyloidosis with diffuse interstitial fibrosis and severe arteriosclerosis. He needed to continue on dialysis, but he was given treatment to try to reverse some of this. So this is AA amyloidosis associated with checkpoint inhibitors. And there are now around 4 cases reported with pembro, nivolumab, and AA amyloidosis with ATN. And some of them do require steroids and infliximab treatment, and some of them do respond, some don't. But this has been now an established pathology associated with checkpoint inhibitor. And this is another case of an 80-year-old metastatic squamous cell cancer diagnosed October 2019, hypertension, hyperlipidemia, nephrotic range proteinuria. Patient also had a history of renal cell cancer, nephrectomy, and chronic kidney disease. We started on, again, a PD-1 inhibitor in 2019, and 3 months later has proteinuria of 8 grams. PLAR2 is positive, and the kidney biopsy confirms PLAR2-related membranous. Now, the question is this de novo or is this drug-induced? Can this be possible? Yes, it's possible that the immune system activation might have triggered a PLAR2 membranous. Just steroids alone made this patient go back into remission. It did not require the full treatment of membranous. So if you look at the systematic view of immune checkpoint inhibitors glomerular diseases, the most common actually is pauci-immune glomerulonephritis, renal vasculitis. We do see some podocytopathies and some C3GNs. Very, very hard to treat these as they don't go into remission, and 34% of them die. But in terms of the pathology, the most common is minimal change disease, FSGS, AA amyloidosis, and membranous. But by far the most common is the pauci-immune vasculitis. A lot of them are not anti-positive, and there is no hydralazine as a second hit. And finally, just one slide to end that the checkpoint inhibitors in the kidney transplant patients lead to acute rejection. This is the largest series to date of 69 patients. And you can see that 42% of them got rejection within 24 days, and 65% of them had graft loss. So it's important for you pathologists to know that when you get these patients with checkpoint inhibitors and rejection, it probably was triggered because of the activation of the immune system.